webinar on foundation restorations. My sincere thanks also to my colleagues, Dr. Rahul Srivastav and Dr. Mollishri, who are being at the back end moderating this event. So thank you very much for taking time out. The topic that we're discussing today, called foundation restorations, in general terms is commonly referred to as post and core. Students would remember this topic from their third and final year days as post and core. Somehow the word or the topic called post and core gives a very theoretical and a kind of a boring kind of impression. So when I was doing my graduation and once I did my post graduation, I kind of decided that if and when I would lecture on this topic, I would kind of tweak the heading a little bit, and that's exactly what I did today. And I've named it Foundation Restorations because I've tried to include a lot of clinical aspects into this presentation today. We have a lot of cases that I will be sharing and discussing with you on the aspect of post and core. And at the end of the session, I sincerely hope it's benefited both the practitioners who were attending the who are also attending this webinar. So with your permission, sir, can I start my screen share?
Sure, Sagar.
Thank you, sir. Just give me a moment, please. Okay. Dr. Nayak, I hope it's pretty clear to everyone out there.
Yeah.
Okay. So I usually start my lecture by showing this first slide because this is the common appearance of a patient that visits us in the dental office when he is in pain. And the general assumption when you see a patient in this condition is, you know that he's in trouble. This is a pulpal kind of pain, probably progressed into the periradicular region, and that's the reason he's in. Now, usually, whenever we see a patient like this, the medical or the doctor side of ours comes out, where we kind of empathize with the patient and we kind of feel bad for him and we're keen to treat him. But thanks to Corona, which has kept us kind of confined to our homes and not allowed us to practice and has kept us basically jobless, if we get a patient like this walking in today, this is the normal standard response that you will get because you're looking at making some kind of money out of it. And if you see the patient clinically and you realize that he needs a build up or maybe a post and core as to what we are going to discuss today, then this is the second response that you will get. That is the Dusra Laddu Futa. Now I am trying to be little hilarious when I start my presentation. Not consider this to be an endodontist. Let this be any practicing dentist. Let this be any intern. Let this be any student. Let this be any specialist of any branch. If there is a carious tooth seen, the first approach should always be to salvage the situation rather than having the concept of extraction and now with the boom of implants coming in, place the implant. So I always believe the first and foremost effort by all of us should be to make sure that we are able to save a badly mutilated tooth, which is of course where the concept of foundation restorations will come into the picture. Now, I'm here to talk about post and cores, but I'm not here to talk about a case like this. This technically is also a post and core, if you see. But is it done in the right way? Is it done in the right principles? Is it done in the right science? The answer is no. So we would understand what are the right techniques of doing a post and core, right aspects, right philosophies, and the right predictable science to make sure that the post and core that is done lasts with the patient for an extended period of time. Now, For general descriptive purposes, if you have to define or understand what a post is, it's basically a rigid restorative material which is placed in the root of a non-vital tooth. In simple words, it means that the root or the tooth is endodontically treated, and then you have a rigid restorative material which is placed in it. It extends coronally to anchor the core material, which then supports the crown. So that is in short what a definition of a post is all about. Coming to the core. Now the core is basically the supragingival portion which is replacing the missing coronal tooth structure and creating a non-vital it. In other words, you've created a miniature crown on which you are going to have the actual prosthesis coming into place. So this is a basic definition or description of what a post and core is all about. Now, this is a very, very simple way of understanding how you do the post and core right from the beginning. So if you understand, sorry, if you understand how I have tried to do the explanation over here, say for example, you have a root canal treated tooth. Once you do the post space preparation, you are going to have an apical 4 to 5 millimeters of an apical seal of gutta percha that is supposed to be maintained. The balance part of the root is where your core comes into the picture. The post comes into the picture, I beg your pardon. Followed by that, you have the core build-up material. And in the end, you have your final crown that comes and sits in place. So this is the right way or the right technique in which we would do a post and core restoration. Now, what is your purpose of doing a post and core? It basically has two functions. Number one, it helps in retaining the core. And second, it helps in favorable distribution of stresses throughout the radiculodentine portion. Now, I want to make one point very, very clear in this part itself. There is a general misconception that a lot of people have that when we do a post and core, we are actually strengthening the tooth. The answer to that is no. We are actually doing exactly the opposite. We are actually weakening the tooth more. The reason we have to do a post and core is primarily because the remaining tooth structure that you have post your endodontic treatment is too incompetent or compromised support for your core buildup and subsequently the crown. That is when the post and core is actually done. So please remember that when you do a post and core, you never ever increase the strength of the tooth. You actually weaken it more. I've seen a lot of doctors probably telling me, I did a post and core, I increased the strength. I've seen doctors telling their patients or the patients coming to me, who've got themselves treated elsewhere and said the doctor did a post and core treatment and he increased the strength of the tooth. No, that's not the case. You are actually weakening the tooth more because you are removing more amount of radiculodentine to incorporate the post into it. Okay. Now, a starting part of my lecture is a little bit of theoretical part because I need you all to understand the basic requirements and what exactly a post and core is all about. So when you come to the ideal requirements, what a post should have, basically it should provide maximum protection to the root to resist a root fracture. It should provide maximum retention to the core because that is the primary reason why a post is even done. It should be easy to place. No one would want to do a procedure wherein it's very cumbersome to even place the post. It's going to be difficult for the operator and difficult for the patient who's undergoing the treatment. It should be as less technique sensitive as possible because you do not have the most ideal conditions in the oral cavity. For example, if I say a post should not have any kind of fluids in the oral cavity at all, it's a technique sensitive procedure because there is no way you're not going to have saliva in the oral cavity. If you say that the post is going to get affected by the slightest amount of moisture, that's not an ideal requirement of a post. It should be able to have as less as technique sensitivity as possible. It should have strength and fatigue resistance. Very important aspect, it should be visible radiographically. at to which the post has been placed to be able to figure out post the placement whether you've placed it to the right length or not. Of course, it has to be biocompatible. You cannot have a post placed in the oral cavity which is going to have any kind of harmful effects or repercussions on the patient. Easy to retrieve if required. Well, that's a worst case condition. You never start doing a post and core with the assumption that I am going to retreat it. But worst condition, if the case fails, be it done by us or be it done by anyone else, it should generally be able to retrieve well so that we can retreat and save the tooth. Aesthetics is in big demand now. We are not in the 1990s or the early 2000s or maybe the 2010s where the patients are okay with slight amount of aesthetic compromise. Patients have big aesthetic demands now and they want to look fantastic. So you need to have the most aesthetic post available. Of course, it should be easily available, and last but not the least, it should be non-expensive. You do not want expensive posts in an Indian scenario which is very dominated by the economic factor. So these are your ideal requirements of post and core. Now, if you do a broad-based classification of what the posts are about, it's basically classified into the metallic and the non-metallic versions. The metallic ones come into two types, that are the custom-made and the prefabricated one. Now, just for simple understanding for students who are a part of this lecture, in simple words, when I say custom made, it means fabricated to fit exactly in the tooth. In other words, in a simple way, I can say it's the stitched garment, and a prefabricated post is a ready-made garment that you pick up. So prefabricated posts come in prefabricated sizes. They are ready-made vis-a-vis a custom made, which is actually versions come into either a passive tapered, a passive parallel, or an active post. The non-metallic ones are the carbon fiber, the glass fiber, the ribbon, the light transmitting one, and the ceramic one. So we will be discussing each and one of these with clinical cases as we go ahead in today's lecture. Now, when I said they're classified, they can also be classified as active posts and passive posts. When I say active, means it is actively screwed or threaded inside into the root. Not recommended at all. It should never ever be active. Yes, there was a time when active posts were predominantly used and suggested and marketed. Not anymore. They have a huge sense of, or a huge case failure rates that have come up with active posts. So the post primarily should always be passive. Okay. Now, when you see prefabricated posts, you basically have the metal posts that we will start with during our discussions. Now, in the metal post, as I described, you have the passive and the active ones. Now, this diagram tells you very clearly, if you have the threads that are actually having to be threaded or screwed inside the canal space, that's an active post. Whereas if you have the post which is just placed very easily inside the canal space without having to use any kind of screwing in force, it's a passive post. Now, this is the most commonly used, inexpensive, easily available of all the metal prefabricated passive posts. So please understand what I said. It's the metallic version of the prefabricated ones, and it's passively inserted. Whereas a case like this, these are your active posts. Now, these were used in the earlier part of dentistries when the kind of posts just came into the picture. If you see, these are posts which are called this is your key that is actually used to engage the posts, and then it is threaded or screwed inside the canal. Please do not use them. They are probably the worst of the kinds. What are your advantages of the metal posts? Extremely simple to use. As I said, remember, technique sensitive. It should not be very technique sensitive. So this metal prefabricated post, very simple to use, less time consuming, so you can get done with the procedure very easily, easy to retrieve, which is not the case with fiber posts, and we will discuss that when we come to that. It is available in various shapes and sizes, so you got a lot of options because each and every tooth is going to come with variable anatomy. So you need to have various sizes available with you so that you get your choice in front of you when you actually are doing the procedure. It's radio opaque, which will help you understand the depth at which the post is placed, which is right or wrong, and it's extremely economical. So these are the advantages that come with the metal prefabricated post into the picture, and they're pretty good advantages. However, anything that has their advantages will always have their share of disadvantages. There's nothing called as a perfect material. The problem with metal posts, number one, is root fracture. And I'm going to discuss this in detail as we progress ahead with the help of a video that I have shown you. I will be showing you. So root fracture cases are very predominant with metal posts, more in the active ones, but even seen in the passive ones. As the name says, metal. So obviously aesthetics is totally compromised. Of course, you got now options with a zirconium cores and also that you can mask the metal post inside, but still you will never get the best aesthetics the moment you have a metal post placed inside. Obviously, it's going to give rise to corrosion products because it's a post removal in certain cases is difficult, especially if you've used say a glass ionomer cement, for example, to lute the post. We will be talking about the cementation protocols ahead as well. It becomes a little difficult to remove. And of course, the biocompatibility is a factor because of the principle of galvanism that you have. Now, this is a very simple clinical image to understand what exactly happens when you use a metal post, more predominantly an active one, but in certain cases, even a passive one. Now, please don't generalize a case coming to you or your case ending up in a situation like this if you do a metal post. No, that's not why I wanted to show you the slide. Why I intend to show you this slide is if a metal post is not planned correctly and done based on the diameter of the tooth, a wrong diameter post is selected, you can actually cause more harm than good by having a situation like this coming into the picture. Also, it's very important to understand the root morphology before you decide to place the metal post, because every root is different in cross section, every root is different in diameter. So all these aspects need to be taken into consideration before you place your metal post inside. Now, I'm sure everyone recognizes him very, very predominantly. I don't need to introduce him. Everyone's heard my introduction thanks to Dr. Nayak. I don't need to introduce the gentleman who's standing next to me. Whether I did a post and core for him, the answer is yes. Whether I'm going to show you his case, the answer is no. Instead, what I'm going to show you is a gentleman called Mr. Mishra, who came to my practice in the earlier part of my career when I just finished my post graduation and I started my practice. Do not generalize the lecture or the clinical cases that I show you as a standard procedure. Let's say, for example, if Sagar has to travel from Bombay to Bhopal, he has air route that he can take. He can come by train, he can drive down and come. What I intend to say is I have multiple methods of reaching my destination. Similarly, when you see a clinical case, you have a multiple you can have multiple approaches to the same case. If I do this case today, I'd probably approach it in a different manner. When I did it in the earlier part of my career, I did it a little differently. But there is a reason I did it. I had just started my career. This patient is not very affording. This patient had come in with one of the most poor oral hygienes. And let us meet Mr. Mishra. So Mr. Mishra walks into my practice like this, and he says in his very typical UP accent, "Hamri biwi humse naraz hai." So I, in my mind, say, well, that's kind of common. All wives are always annoyed with their husband. Tell me something new. So he says, nahi, Dr. Saab, hamri biwi humse naraz hai. So at first I thought that I think he's come to the wrong person. I thought he needs a psychiatrist. So I wanted to tell him I'm a dentist. You've come to the wrong person. And then he shows his teeth like this. And he says, Dr. Saab, hamri biwi humse naraz hai. I said, okay, now I understand why your wife is annoyed with you. So this is the pre-operative clinical situation that Mr. Mishra walks into the practice. Now, there are a couple of things you need to understand. Whenever you see a preoperative case, please do not jump into the situation without planning the case, because you have multiple aspects of restoration. You have a functional aspect where you need to restore his teeth. You also have an aesthetic aspect because it's an anterior tooth, so you need approach the moment a case walks in, because that is exactly what the earlier dentist did. Now, please notice the slide carefully. What Mr. Mishra has done is he's visited another dentist, and that dentist has treated him for the root canals for 4 of his anteriors. And that said, sorry, I cannot treat anything further. I don't know what to do about it later. I'm kind of clueless. I don't think these teeth can be salvaged. You've sorted with the problem of pain, but how do I proceed ahead? So the first thing now we do is to start analyzing the case. Now let me explain you how you would analyze the case. Let's look at his central incisors. You are having absolutely bare minimum of supragingival tooth structure. If you look at the gingival profile, his gingival, or what I call as perioaesthetics, is totally compromised. Why do I say that? Is because you have something called as the gingival finish, where your attachment or your margin is supposed to end. Now, if you see his central incisors, they are at a much lower level vis-a-vis the lateral incisors and the canine, which is exactly opposite at what it's supposed to be. This position of the gingival part is supposed to be practically in line with the canine, if not more. So we have to, along with the post and core, also have some amount of periodontal planning for him to get the perioaesthetics also sorted out. That's why I say when you see a case in the beginning, always analyze the case totally before you jump into the picture. So this is the preoperative situation as Mishra ji has walked in. And what if I tell you I finished this case 10 years ago, just in the beginning of my practice with something like this, not having the best of lab support at that time. Mentioned, not a very affording patient, but I have still managed to finish this case like this with PFM crowns. Let us understand how we've gone ahead and done this. So the first thing we plan is, of course, you need posts for those badly mutilated teeth. But what you will also notice is I have done certain amount of crown lengthening over here, over here, over here, and over here. In other words, I have gotten his perioaesthetics now more or less sorted out, along with the aspect of ferrule effect. Now we're going to talk in detail about ferrule in the latter half of my lecture. But if you notice over here, along with the aesthetics of the gingival aspect of your treatment, I have also created the ferrule to make sure that my tooth is sound enough to receive a core and a crown on top of it. Okay. Now, the instrument of choice when you have to do gingival contouring is what I call as the electrocautery. You have the lasers which are also available. I am a big fan of the electrocautery because it's extremely quick. Personally, what I've noticed with the laser, I know the proponents of the laser will kind of disagree with me, but I tend to get a very clean cut when I use the electrocautery. Plus, the healing aspect is much quicker. I'm talking about the new electrocauteries, not the traditional electrocauteries, but the newer ones. So that's my cautery of choice that I use for gingival contouring that I have to do, which is what I did in his case. Once you've done that, you then have the BISC trials that are coming in. As you notice in the BISC trials, you make your adjustments, you make the points to be conveyed back to the lab, what has to be changed, and you finish the case. After we have done the electrocautery, is still in the healing phase, because this photograph I took immediately after completion. You will still notice it's almost 100%. I would not say it's 100% because you would need some amount of time for 100% pink appearance to come. So you would see a slight band of red, but over and all, I think the case has been completed quite well. Where I would do something different today, since I mentioned in the beginning of my lecture, I may have approached this case differently today. I would have gone ahead with a fiber post. Two reasons. A fiber post would have been a little more aesthetic. Second, as you will see in my presentation in front, there is something called modulus of elasticity. Now, modulus of elasticity of a metal post is way higher as compared to the dentine or the natural tooth at which we are placing your post in. Vis-a-vis a fiber post, which is having the modulus of elasticity closest to the natural tooth. Now, we'll understand that again as the lecture goes on. But what I would have done differently, as I said, I would have probably gone ahead with a fiber post in this case, and I would have probably suggested metal-free crowns, provided he was ready to pay me. That's very important. Okay. Now, if you see the before and after, now here is where I want you to notice the pink. Why I showed you the earlier slide before is I wanted you to understand that the tissue takes some time to heal, whereas here you will see the pink is back. And the moment you know the pink is back, you know that the gums have healed, and they've healed well. The PFM crowns have done a fantastic job. This is just to understand and probably let you all know that don't think metal free is your only answer. Yes, if the patient can afford it. Yes, if the patient demands it, there is nothing like a metal free crown and a fiber post. But if you get a compromised patient, please do not hesitate to do something like this, because you can achieve fantastic results even by doing a case of a metal post and a PFM crown, rehabilitating patient to an ideal smile back. Okay. Once you cover the metal post, I now want to come to the non-metallic posts. Now, the non-metallic posts started to come in the, I would say predominantly came into the market. Of course, they've been in the market for a long time, but they started to, kind of push it into the market in the later half of the 2000s, big time. It was available earlier, as I said. So when I did my post-graduation also, we had the fiber post, but the marketing of that was limited. Now you have fiber posts which are being pushed through and through by the companies because they've become more cheaper. They were expensive when they had earlier come into the picture. Now they're much cheaper. So the non-metallic posts can, if you remember the classification, as I said, it's either the carbon fiber or the glass fiber post, which is surrounded by a matrix of polymer resins. It tries to match the flexural modulus or modulus of elasticity of dentine. That is the main advantage of a fiber post vis-a-vis a metal post. The modulus of elasticity is the closest to dentine or natural tooth, which is not the case with a metal post at all. Okay. Now, Himanshu ji, can I just request you to play that video before and then I proceed ahead, please?
Sure.
Now, I want you all to have a look at this video that I'm playing right now. So please notice this very carefully. What exactly happens? Okay, that should be good, Himanshu ji. Thank you.
Excuse me, sir.
Yeah.
I guess we need to play it again because it was lagging, I guess. It was good?
Okay, I'm okay. I think it was good because I could see it as well.
Perfect.
Yeah. So can I get back to my screen sharing?
Yes, please.
Yeah. Now, you all may wonder, why have I shown you a video of a train running over a track? it's kind of confusing. I mean, why would a dental webinar want to teach you mechanical engineering? I mean, it's a common question that can come in everyone's mind, that why is this guy, is he in his senses? He's trying to show us a video of a train moving over the track. If you remember, I said have a look carefully. Please understand, when the train moved over the track moved down, and the wooden planks which are placed under the track also moved down along with it. Now, when you place a post in the tooth, you build up a core and you place the crown. When the patient starts to chew, with the masticatory forces, the tooth moves inside the socket exactly the same way as the train is trying to push the track down when it is. So just showing you a visual here, the wooden planks as the root. Now in the train, if you notice, all the three move in unison when the train moves on top of it. That does not happen if you've used a post with a modulus of elasticity which is different from dentine. So what happens is, when the patient is chewing or masticatory forces are applied, the tooth moves inside along with the forces, but the post, because it has a modulus of elasticity which is higher, remains stagnant. It is just the tooth moving. That disturbs the bond between the post core and the tooth, and also increases the susceptibility of the fracture. I hope I have tried to make my point in a very simplified way by giving you a simple example. If you have not understood this aspect, please come back to me at the end of the lecture and I will explain this to you again. This is where the importance of using a fiber post comes, because its modulus of elasticity being closest to natural tooth. So when the patient is chewing, it moves inside in unison. So when the patient chews, the tooth, the post, the core, and the crown move in one unit, because all of them have a modulus of elasticity which is more or less close to each other, as compared to a metal post which is having a very high modulus of elasticity. So it says, no, I am not going to move. I am the stronger person. The root, of course, has to move. And that is where the problem of forces on the root come into the picture, fracturing, dislodgement of the post and core and the crown coming out, all those things happen together. So when you see a case, you need to ask yourself these questions. Is cosmetics important? I believe it's important in any and every patient. You got to give importance to cosmetics. Is the patient at a higher risk of fracture? You'd see based on clinical situation. If he's a bruxer, if he's a tobacco chewer, if he's having these habits, yes, he's at a higher risk of a fracture, excuse me, as compared to a normal person. Are the fundamentals of post and core conditions present? Here is when you look at ferrule. Now, I've been talking on this word ferrule. That's where my fourth point is. Do I have an adequate ferrule? Now, I don't want this to be, kind of rocket science to everyone. So I'm just going to give you a brief description of ferrule before I go ahead. In simple words, a ferrule effect is about 1.5 millimeters to 2 millimeters of sound tooth structure present supragingivally 360 degrees. I repeat again, 1.5 to 2 mm of sound tooth structure. I repeat, sound, not decayed or compromised tooth structure, present supragingivally, 360 degrees of the tooth. That means you have a good ferrule effect. If any of these points are compromised, you have a compromised ferrule effect. So based on that situation, you will choose your post. Simple words, if you have a good ferrule effect present, always choose a fiber post. If you have a compromised ferrule effect, try to create an ideal condition by doing crown lengthening, as I showed you in Mishra ji's case, and get it to a normal condition, and then use a fiber post. If you have a compromised ferrule effect irrespective and you cannot achieve, only then do you actually prefer a metal post. I hope you've understood what I wanted to say so far. The carbon fiber posts were the first of the non-metallic posts that came into the market. Now, this is just a simple kind of picture to explain you when the carbon fiber posts were launched, they came in these variable sizes. You know, you could see some parallel ones, some tapered ones. You got various options which are available. These were about 6 to 8 microns carbon fibers arranged longitudinally in an epoxy resin matrix about 64% by volume. Now, one major disadvantage that a carbon fiber post had, that any kind of immersion or contamination with water reduces its strength or stiffness by 60 to 70%. So if you go back to my slide on ideal requirements of post, when I said it should not be technique sensitive, this post becomes extremely technique sensitive because you are no ways going to have no moisture in the oral cavity. Agreed, you can use rubber dam. Agreed, you can use a lot of high wax suction. But irrespective of that, to have no moisture is very difficult. That's the main disadvantage of a carbon fiber post. As soon as it has contamination or contact with moisture or water, there is a reduced strength by about 60 to 70%. That's a tremendous amount of strength loss. So it really eliminates the entire purpose of using a carbon fiber post. That's why it did not become very popular, along with the aspect that it's aesthetically not very pleasing because it requires a lot of okay. Now, the earlier ones, the carbon fiber came from this company called Mirafit Carbon. Uh, I'm going to show you a clinical case that was done by me in the earlier parts again. Probably, if I remember, this is one of my post-graduation cases, but because it's been documented, I can show it to you. Uh, what you notice in this case, you notice a couple of things. You notice that a 2-unit crown has come out. The remaining part of the tooth structure is at the gingival third, at least in the first premolar. The second premolar still has a decent amount of tooth structure present supragingivally. So what is the common error that this could have been? When the crowns were placed, the ferrule effect was not taken into the picture. That is why it's broken at the neck of the tooth. It breaks with the core together when the ferrule principle is not taken into consideration. What do we normally tell the patients? Well, you had something hard. See, my crown is still intact. No, it's not the patient's fault. It's the dentist's fault that he's not followed the principles of ferrule when he gave the crowns. In simple words, his margins were probably sitting on core rather than sound tooth structure, which is where they actually should be sitting. And that is why the whole thing breaks up and comes out. Now, what do we start with this case? You first start with the post space preparation. So the ideal drills that are used for your post space preparation are your piezo reamers. You usually start with piezo reamer 1, you progress to 2, you stop at 2 or go to number 3 depending on the root anatomy, which of course we will discuss in the latter part of my lecture as to how much your enlargement of the post space should be. Then have the carbon fiber post placed inside. Himanshuji, is the video clear with everyone over there?
Yes, sir.
Okay, because I'm getting a lag here. I just wanted to confirm. Thank you very much. I then place the carbon fiber post into the prepared canal space. It is here that I mark as to how much of my height of the carbon fiber post I need supracrestal, supragingivally above the tooth surface to retain my core. I mark that. Very importantly, I will not section the excess part of the carbon fiber post inside the oral cavity because of two reasons. If I have to do it inside the oral cavity, I will be either using the aerator, which will use moisture. I will also generate moisture from the oral cavity because of saliva, which will contaminate it. So I remove the carbon fiber out, take a carborundum disc and section it at the point at which I mark. I will then place the carbon fiber post back inside. I will then dry my canal with a paper point. Now at this point, I want to bring up this aspect before I go ahead. that whenever you are having a post cementation, prior to cementation of the post, it is very important for you to dry the canal space. You cannot have a wet canal space because you're going to have any kind of cement that you use for cementing or luting or bonding your posts is going to have an interference with the presence of moisture. So you need to dry it. So I've shown you a picture where I've dried it with a paper point. Once I dry it with the paper point, I will then have my cement. That's a dual cure cement which is placed inside. You agitate it with a carbon fiber post. You agitate it carbon fiber post to the desired length, and then I will light cure it because it's a dual cure cement. So I will light cure it because I said since it's dual cured, the part of the cement which gets access to the light gets hardened by light. The part of the cement which doesn't have access to light will do a dark cure or a self setting. That's called as, the technical term for it is called dark cure. Dark cure means the light cannot reach over there, and that's why it's called dual cure. It's got a double mechanism of setting. Once that is done, now please look at these images very carefully. What I have done, I've actually taken the same crown back and loaded it with a core build-up material, a dual cure build-up material like a paracore or a luxa core. I have placed it back on the tooth that is being treated. I will remove the excess cement, and now I remove the crown back. What I have done with the same old crown is created the same core back, which was present earlier. Now, what was the problem in the earlier part of the case? Compromised ferrule effect. So to adjust that, I have done crown lengthening. If you notice the first premolar, I have done crown lengthening over here. That has established a good ferrule effect. In other words, I have exposed the part of the tooth structure which was subgingival is now supragingival, which is a healthy tooth structure. Of course, following the principles of periodontium over here, wherein you in certain cases even need to do osseous reduction. We're not going into the details of that in this lecture, but we follow the principles of periodontium over here. Same crown lengthening over there, and then the same crown for the moment can be temporarily cemented back, and we take impressions for a new crown. Why we take impressions for a new crown is because you do not want your crown margins to be short. What we've done with crown lengthening is actually extended the margin. So the earlier crown is actually going to fall short on the newer bit of tooth structure which is being created. So I have done this, but I use the old crown just for temporary cementation because I always believe you should never send the patient back by just doing a post and core. You must always temporize. It's very critical. This aspect of dentistry is ignored by many. That is the temporization aspect, which you will see in the further part of my lecture, how we've temporized the case. So you always temporize it and send it always. And then you get the final impressions done for the new. Now, because it was a post-graduation case during those days, of course, you got to send it to the Department of Prosthodontics and they would do the crown. So I don't have the follow-up pictures of that. But that's how we approach this case with a carbon fiber post. This is a very simple diagram to understand where the aesthetics comes into the picture. Now, what you see in the first image vis-a-vis the second image is either a metal post, maybe even a carbon fiber post vis-a-vis a glass fiber post. You can see the light actually passing through. The best aesthetics are achieved only then because you get the real translucency, which you will never be able to achieve if you have a metal post, because the light is going to hit and bounce back. So it's going to appear very artificial or like a rock vis-a-vis a glass fiber post and a metal free crown where you're going to have light pass through it. So you're going to achieve the best aesthetics and the best translucency possible. Coming to the glass fiber post, probably the most common post for most of the cases. I would say for almost all cases, unless you have a very, very poor remaining tooth structure. Then I would probably recommend you to go for either a metal or a custom made post, which we are going to talk about ahead. Now, where does the advantage of a glass fiber lie? Now, probably from my experience, the best glass fiber posts come from Colteen. They come as para posts, not because I speak for Colteen or I'm a key opinion leader for them, but I genuinely believe they have probably one of the best fiber posts that are available in the market as of today. Uh, Patients now demand metal free crowns. They demand aesthetics. This is the generation of what I call as the instant coffee. They want things fast, they want things good, they're ready to pay you, but they want results. And that's where glass fiber posts fit the bill. They give you the best aesthetics. They're pretty economical now with a lot of new companies that are coming to the picture, and they are extremely popular. What are the advantages? Superior aesthetics. I've already discussed about it. Very, very good modulus of elasticity, because with modulus of elasticity being close to dentine, you have minimum chances of post fractures, root fractures, post and core debondings. So major advantages over there. Of course, because it's a glass fiber post, you have an option of curing the light through it. So the light can be carried into the deeper part of the canal with a glass fiber post, and the curing, or what we call as the deep curing, is achieved very, very effectively. Superior aesthetics, I'm going to talk about this again and again, but the glass fiber posts give you the best aesthetics as compared to any of the posts that we've just discussed about. What is your ideal design for a good aesthetic post? More than the retentive uh, aspects that are incorporated in the design of your post, you need to have a combination of micro or macro mechanical retention that is incorporated in it. So I go back to the previous slide. You need to have a good head over here. So this part is very critical to make sure that it retains the core. This part of the post which is going inside the canal should have micro or macro retentive grooves which are present to help in increase retention. Of course, with the advent of dual cure cements and very, very good kind of bonding agents, that is kind of getting out of the picture, but it always helps. Now, whether I treated this beautiful lady that you see on the screen, Chitrangda, the answer is yes. Whether I will show you her case, the answer is no. Why I brought up this image over here is because you will get young girls, you will get young patients asking you for increased aesthetic demands. And that is the time you cannot tell them that I'm going to be giving you a PFM crown or a metal post. So the fiber post, the metal free crowns now come into the picture. Whether I treated Veerdas, the answer again is yes. Whether I'll show you the case, the answer is no. But I'm going to show you Nagesh's case. Now, this is a case that I did in conjunction with my very dear friend who has been my mentor and guide as far as aesthetic dentistry is concerned, Dr. Akhil Reshamwala. I think we were all privileged enough to hear his webinar a couple of weeks ago, where he spoke on some of the very, very basic but useful aspects of crown preparations and temporizations, an extremely useful seminar. So we did this both together, and you can see the result at the end of the day. So Nagesh comes and says that, okay, I have a dislodged crown, look at what is there inside. I don't like this appearance, sort me out properly. So what do we do for Nagesh? We first remove all the decayed part that is uh, kind of present on the tooth surface, make it an extremely clean, caries-free tooth surface. That's very important. Once that is done, you then take the glass fiber post. Now, if you see over here, what I've shown is a glass fiber post, which is placed inside. The concept of preparation of the pore space remains the same. So as compared what I did in the carbon fiber pores, we use piezo reamers. The same principle is used in a glass fiber pores. Piezo reamers are your drills of choice for pore space preparation. I've used the glass fiber pores. What I've tried to see over here is the fit. We then check the fit and cure it. If you remember what I mentioned in the earlier part of the slide, the glass fiber post has a capacity to carry the light deeper inside. So it's very easy to loot the post internally into the canal space, and you're going to get a very good curing deep inside, because the light can pass through the glass fiber post right to the depth of the post space. Now, this is the case wherein we did the second option. What we've done over here is we built the coronal part of the tooth with composite resin. You can either do that, or in the cases that you will see ahead, which we've actually done, I have built this part also with the dual cure material. Now that's the practice that we follow. This is also one of the cases that we did about 2013-14. Things have changed since then. I'll show you some of the recent cases as well. So once the glass fiber post is cemented, you start to incrementally build up the coronal part with composite resin. Once the coronal part of the tooth is built with composite resin, the remaining part of the glass fiber post is then sectioned out. The difference between the carbon fiber and the glass fiber is here water does not have any effect. So you don't have to then worry about it. In the carbon fiber, if you notice, I sectioned the excess part of the post extraorally. Here we don't have to worry about that. We can do it intraorally. So we section that excess part. We've done the final crown preparation over here. Always, this is where I talk about the concept of temporization. It's very critical. This is one aspect of dentistry which is somehow ignored. So what we do for temporization before we start the case is we take a pre-operative impression either in alginate or maybe putty, whatever you want. And in this case, we've taken an alginate preoperative impression. So that acts as a template. Then we do the post and core. And in the same space in the tray, if you see, I have actually flowed in my temporary material. So the temporary material that you can use can be either something like a cool temp from Colteen, or you can use any of the ones like a Luxa temp or a Pro temp from Densefly. Either of the ones are good. I personally like cool temp, so that's the reason I mentioned about it. Once you've flowed the material on that, you will then place it intraorally into the patient's mouth in the same position. Allow it about 2.5 to 3 minutes to set. The moment you allow that and you remove the tray, this is the cool temp, which is kind of fabricated as in accordance to the preoperative condition. So the preoperative impression helped us as a template to fabricate an immediate temporary on the chair. So you see a lot of flash around. So you remove that. This is the temp that has come out. We then finish the temp and you send the patient with the temp. Obviously, there is no ways that you're going to tell the patient to go with a prep tooth outside. There is no ways. Nobody's going to like going out, and trying to hide his smile. So you got to learn the aspect of temporization. It's a very critical aspect from the aesthetic point of view, but also the functional point of view. Because you don't want, for example, if you've done a crown lengthening, you don't want the gingiva to kind of regrow. You don't want an accidental kind of force coming. So the patient has had something hard by mistake and it kind of, has an accidental impact on the whole effort of post and core that has been built up. So always temporize the tooth before you send it out. Once the patient comes back, probably after about 2 to 3 traction, so the margins are very well visible. You then take the impression and do your shade matching, and then before cementation you clean the root tooth surface to where the crown is supposed to come very nicely. You scale it properly, you use pumice, you clean it nicely so that it's a fresh clean surface prior to cementing your crown. Okay, so that's very, very important that we follow these aspects to achieve the desired aesthetics at the end of the day. What did we understand in this case as a crux? If you have a decent ferrule effect, which is what this patient had, he had a reasonably about 1.5 to 2 mm of sound tooth structure supragingivally. Once we've removed all the decay, glass fiber post is your post of choice because you achieve the best aesthetics with it. What I've done in this case is kind of build the core separately and looted the post separately. We can do that in a different way, which you will see in the further cases. You do the preparation, immediately temporize the case, always. Never send the patient without a temporary. Recall the patient probably after 2 to 3 days for the final impressions, because on the same day, the marginal gingiva is usually, crying, bleeding. It's not the healthiest. You will never get the best margins. You can give a temporary, recall the patient 2-3 days, maybe a week later. The patient is not worried because you've aesthetically sorted him out. Recall the patient, do a good gingival retraction, take a good putty wash impression, deliver him a good crown. Aesthetics achieved, function achieved with a good post and core. So that's your final result that we see over here. We've achieved aesthetics and we've achieved function as well. As I have mentioned again, you have aesthetics or translucency, which is your main advantage of a glass fiber post over the metal post or maybe the carbon fiber post. That's the image that's very important. Post or the glass fiber post is closest to dentine, whereas the stainless steel and zirconia, if you see over here, zirconium is the highest, stainless steel is somewhere over here. You have fiber post very close to dentine. You cannot ever have something exactly like dentine because dentine is unique. That's why they say you must always preserve dentine, never lose dentine, because once dentine lost can never ever be replicated back. Okay. Now, it's another preoperative clinical situation. If you see that it's a kind of a discolored restoration because the root canal is being done, but just a core buildup and the whole structure has been built with a block of composite. So the patient demands an aesthetic change. So what you do over here is you do a rubber dam isolation, you do a post-paste preparation. What I've tried to show over here is something called as the monoblock technique. Now, monoblock technique means that the root dentine, the post, the cement, they all are one unit. If, for example, you use a metal post and you loot it with a glass ionomer cement, the cement is a weak interface. Whereas if you use a fiber post vis-a-vis and you use a dual cure cement and you do the core buildup in one unit, it acts as a monoblock technique. A monoblock is always better for longevity of success of the treatment and achieving good strength. So always prefer a monoblock. So under rubber dam isolation, first the post-paste preparation is done. The glass fiber post is seated, selected. The whole post and core is built up in one unit. And then you have, as always, you take the final impressions, but never ever forget the provisional. This is the cool temp that is flowed into the preoperative putty impression that was taken. The before to the after, it's tremendous. Also, the fact that we've got a good post and core in place, so it's made sure that the tooth is now sound and can take the load of masticatory forces quite easily. It's another case of a lateral incisor. If you see, it's a compromised lateral incisor broken down. We've done a glass fiber post selection and we've then had a crown placed on it. The only problem with certain glass fiber posts even today is they are not radiographically visible. You have the newer ones which are pretty much giving you that option, but you see an image over here, you don't have a radiographic appearance of that. So it tends to make sometimes an issue as to whether I have gone with the post length totally or I have not. So that is where the advantage of the newer glass fiber posts come into the picture, is they allow some amount of radiographic visibility. Let us understand now Shashikala's case, which is a regular glass fiber post. But here there is a slight difference. So she reports and says that I don't like my central incisor. It looks different. It doesn't look good. I need to get it sorted out. So that's my preoperative image. I take another image with the smile to check my smile line to make sure that if I need any amount of gingival contouring to be done, which is, hello? Okay. Uh, this is the image of the tooth after the crown's been removed. So you notice there has been a lot of breakdown underneath the old crown, and that has given rise to discoloration. It's given rise to secondary caries. So all that needs to be cleared out. So once you've removed all the remaining decay, what you see over here, I repeat again, is a decent amount of ferrule. Now you can see that this is supragingivally 360 degrees. So that's where I have a decent amount of tooth structure present. That gives me an option of going ahead with a glass fiber post. So I do my post paste preparation with a piezo reamer. I then start preparing my glass fiber post. So you need to then apply the conditioning and the bonding on the glass fiber post and keep that ready and separate. You will then etch the tooth surface to make sure that you removed any kind of smear layer, any kind of debris, any kind of contaminants which are present over there. You will then apply with a micro brush the bonding agent, which goes deep inside to apply the bonding agent nicely well coated on the canal walls. You will then have a good isolation done to prevent that there is no amount of salivary contamination that comes into the picture. You then take your dual cure cement, which could be a paracore. I prefer the paracore, and I'll speak about it in the latter part of my lecture as to why I prefer the paracore. Uh, you then place the paracore deep inside with the glass fiber post. You can then loot it. Because it's a glass fiber post, the light gets transmitted deep inside and cures the cement in the deeper part. So this is when you see with the light cure that has been done through the glass fiber post, the light goes deeper into the deepest part where the post ends, and the entire thing is cured, and you achieve the monoblock phenomenon over here. The part of the crown structure or the core is then used with the same, built up with the same material. That's the monoblock effect that I spoke about. The excess part of the glass fiber post is then sectioned out with the aerator. As you see, that's come out. And then you do your crown preparations, which are done according to the basic principles. Is this aspect of healthy tooth structure and the margins which are sitting on sound tooth structure and never on the core. You can never have your crown margins sitting on the core material because you're going to have the crown and the core fracturing and coming out, which is similar to the case that you all saw in the carbon fiber post. So always make sure that the margin of the restoration, the margin for the crown always sits on sound tooth structure. I will then do my gingival retraction. I will then flow my putty wash material on top of it and then take a putty wash impression. This is immediate temporization that the patient is done with. Patient comes back once the crown is ready, the gums have healed well. I have then done my final cementation and I've completed the case. Why I show you the case pictures from start to beginning is because each and every step is very critically important. From pre-operative photograph to removal of the remaining or the infected dentine, to post-paste preparation, to whether you know you have the adequate amount of supragingival sound tooth structure, to the choice of fiber post, the core, and then the retraction, the temporization, and then the final prosthesis. It's a very, very step-by-step meticulous process that is done to achieve this final result. Anywhere in between, if you tend to kind of miss steps, you will never achieve good aesthetics and good cosmetics. Okay. Now, we've all shown you the anterior cases. Let us now understand if you have to do a glass fiber post in a posterior region, what do we do? So here you see a pretty broken down molar. When I say broken down is whatever remaining tooth structure is there is also not very sound. It's pretty soft, decayed and compromised. So what you do is start removing the remnants of the old used the carbide burr. Never ever use a diamond point to remove the remnants of your old gutta percha example for a simple reason that the diamond points are abraders. The carbide burrs are cutters. So when you have an abrader going and removing the remnants of the gutta percha because of tremendous heat that is generated, the gutta percha tends to stick on your burr. In rare cases, if you're unfortunate, the whole gutta percha filling tends to come out in certain cases. Also for the fact that you generate a lot of smear layer and debris if you use a diamond point. So always use a carbide burr if you come across a case of an old root canal treated tooth with a core fractured that has come out. A diamond point is a better choice because it will give you a clean surface post removal of all the debris. So once the diamond point is used, once the carbide burr is used to remove all the debris, once the remaining part of your decayed tooth structure is eliminated out, you have healthy tooth structure. You will then do your post space preparation. The post space preparation is always done in the largest canal of a multi-rooted tooth. So if it's a lower molar, your largest canal is the distal canal. So you do your post space preparation in a distal canal. Once it's done in the distal canal, you will then have the space that is ready for the glass fiber post to go inside. Now what you see over here is we've marked the length of the glass fiber post which is supposed to go inside to know. Why this is important is the early glass fiber post did not have the radio opacity for us to understand if they've gone till the length. So the marker gave us a reference as to whether the fiber post has gone right to the point at where it's supposed to go. So that tells us whether we've seated the post correctly. You then take the glass fiber post, is built up with the paracore or the luxacore material, and then the crown preps are done as you see over here. Once the crown prep is done, what you also notice over here very selectively is I have done selective crown lengthening over here with an electrocautery, because this is the part of the tooth which was decayed proximally and also it was decayed subgingivally. Now when I have to get my margin for the crown have to have the crown margin sitting, it should always sit on sound tooth structure, never ever on core. And that is why you see we have done selective crown lengthening over here. Uh, Himanshuji, is the audio clear? Because I accidentally got a call from the hospital. So, I hope we've not lost network. Hello? Hello? Okay, fine. This is the crown. Thank you very much, guys, for messaging that you can all hear. Appreciate it. So I have done an immediate temporization over here, uh, which is always necessary for two reasons. That you would not want the gingiva to regrow back. If you've seen, I have done selective crown lengthening on the proximal aspect. So if you leave it open and send it, very likely that the gum is going to regrow back. Never ever forget anteriors. Even anteriors is aesthetics, of course, but posteriors is function. You can never ever send that patient without a temporary, because the moment you do that, you're going to have some amount of migration coming in from the adjacent teeth. You're going to have some amount of supra eruption in the next days till the final crown comes in. Always temporize the case before you send it. Never ever send without a temporary. Okay, so that's the temporary, and then I have a case, the clinical image of the final. That's the crown that's seated over there. Pretty well done posterior case, following all the functions of post and core, created a ferrule that was deficient proximally by doing selective crown lengthening to achieve the desired margin sitting on sound root structure. Okay, now what we've discussed is prefabricated metal posts. We've discussed carbon fiber posts. We've discussed glass fiber posts. We've discussed them in the anterior region. We've discussed them in the posterior region. Let us understand where the custom posts are supposed to be used. Now, if you remember the beginning part of my lecture, I said custom means it is stitched to fit garments, means you have made it as per the tooth that you are treating. So you have a case like these where you have custom made posts which are placed in all the anteriors. Now let us understand the advantages what a custom made post has. It's one of the earliest techniques of post and core which was followed from a very, very long period of time. So it's of course got a history of success. It's got fantastic core retention because it's made as one unit. It's made custom made, so the whole unit comes as one. It's got very, very good core retention, excellent strength because it's made of the best kind of materials. You can change the angulation of the post and core if you desire in an retroclined. You can do that by changing the angulation. And when you have multiple kinds of post and core which are placed, it's cost effective as well. But it also has certain disadvantages. The first main disadvantage what a custom made post has is it takes time. So you're obviously going to take impressions, which we will understand how we take it as I go ahead in my lecture. We will also understand that you need more number of appointments. So it kind of adds on to your number of visits for the patient. And at the end of the day, it has got a higher incidence of root fracture because of the principle of modulus of elasticity. Okay, now how do you basically have a custom made post which is fabricated? You have something called as a parapost cast post. So this again comes from Coltine, which is used for the indirect casting technique. So you have a parapost cast post which is kind of having its vents to allow the escape of the excess cement, and it's parallel sided for a stress free fit. This is an exact diagrammatic representation of how you would do a indirect casting or a custom made post with the parapost technique. So you do your post space preparation with your drills. You then take the impression of the canal with this parapost which is designed for cast posts. You then give a provisional crown. Always, I reiterate this aspect, provisional crown is a must. So you must always give a provisional crown. It is then sent, so this part of your assembly is then sent to the technician who will then do a wax burnout over here, will fabricate the final cast and pass post which is then seated inside, and then you have a crown which is fabricated on top of it. So let us understand the clinical wherein you have practically no ferrule effect present. You have practically the entire part of your tooth missing which has been made by your wax, and this is your custom made para post which is gone inside, on which the wax is kind of modeled around to make sure that you design the core part of the tooth. Sorry, just give me a minute please. You will then have the wax pattern which is ready. Now if you see the wax pattern over here, it has got the root anatomy which is recorded in this, and the core anatomy which has been carved and made in this, and then the whole assembly is removed out, sent to the technician. He will then fabricate it with the parapost, and this is the framework which comes from the lab. This is a one unit post and core together, as you see over here. This part is done in the laboratory. That is where the extra sitting comes into the picture, which is a disadvantage as far as the custom made post goes, because you have additional sittings involved. Also at times this may just refuse to fit, so then you got to repeat the whole impression all over again, send it to the lab, and then he's going to refabricate it. So along with the advantages that it comes, it does come with a decent number of disadvantages as well. So this is how the assembly is then seated in the tooth. You then have a decent amount of ferrule which is present over here as a casting ring which is present over here, the casted ring that's come from the lab. And then you have the final preparations, everything ready for you. have to do a similar case for a posterior tooth, then what you call is a multi-rooted technique, which is called as a bolt and core. Now, I'll be very honest with you. Students, maybe the interns, some of the practitioners may find it a little difficult to kind of understand how this works. This is again one of the earlier cases done. So I have decent amount of recording for it, but try and understand as much as you can. This is one of the best techniques that you can use for severely mutilated posterior teeth. Okay. So now if you have a case of an upper molar, say, which is extremely mutilated, present right on the gingival margin. You got decent roots present, but the coronal structure is practically redundant. And the patient insists that, okay, let's salvage the situation. You can use this technique very clearly. Now, when I meant by the bolt and core, it means that you have something like, just give me a minute. This part, which is your core, which is fabricated separately, and this is the bolt or the lock, which is fabricated separately. The bolt or the lock is going into the prepped canal space, which is the largest canal. So for example, if I'm doing the upper molar, the largest canal is your palatal canal. So that has the bolt which goes inside, and the remaining part of the tooth structure is recorded by the impression, and then the lab fabricates this and sends you. So let us see the images ahead. Maybe you guys will be able to understand it better. So this is how the lab has fabricated it. In a clinical picture, let me give it to you in a nutshell. I have an upper molar which is badly decayed. I have done the root canal treatment. I have done the fabrication of the lab. Now takes the impression. Now, how do we take the impression is what you need to understand. If you remember the single rooted tooth, how I did, you take the para post of the custom made post and you check the fit inside the palatal canal which has been prepped. You will then take putty material, wash material, the light body material, which you all know, which is taken for impressions, and you will inject it inside your palatal canal. Now, when you inject it, always remember that the custom pose that you have is coated with a tray adhesive. It should never be directly placed inside the wash material. So I repeat once again, the light body is injected into the palatal canal. You then have the parapose custom made post coated with the tray adhesive that is then placed into the wash material, allowed to set. Once that sets, take another wash and putty impression of the whole arch, very similar to what you would do for a crown prep. So what now the second part of the impression does is it records the broken aspect of the coronal structure. The first part of my impression recorded my post space. The I'm being told the audio is not very clear. Just give me a minute, please. I hope it's clearer now.
Audio is clear, Sagar.
So, yeah, okay. No, because I received a message saying the audio is not clear. So that's why I kind of reiterated that. It was sent by Ashish Khandelwal saying that the audio is not clear. So thank you very much, everyone. Now, I repeat again, the post preparation and the recording of the impression is done as the first step, wherein I inject the light body into the palatal canal. I will take the custom made custom made parapose my light body. Otherwise, when it comes out, the light body will tear. That is the basic principle of coating your trays also, that you don't want it to come out. So you've coated that and you've allow the light body to set. Then the second part of the impression comes into the picture, wherein you again flow light body into the mutilated crown portion, take a putty and take the full tray impression, like how you would do for a crown and bridge. The whole thing is then sent to the lab. The lab will then pour a negative out of it because the custom cast parapost is a burnout one. So he will then be able to record it. He will give you two separate assemblies. One is the core assembly, and one is the bolt assembly. The bolt goes into the largest canal, which is your palatal canal, and the core assembly records the missing tooth structure. So it's like a lock and key, if you guys understand. And because it's a lock and key with the mechanical retention that you have, the whole thing becomes a solid one unit before the crown is placed. So for extremely mutilated posterior teeth, it's a fantastic technique. I know it's difficult to do. If you ask me now, I'd probably, be like, why not just place an implant? But if you want to really salvage the situation, this is your technique of choice for a posterior teeth, because you get that frictional bonding bolt and core kind of locking mechanism that will make sure that it never dislodges out altogether. So I hope I've tried to make it all clear. So here, if you see, I've placed the core separately, the bolt goes in separately, and then it's cut out. That's where you see the bolt has gone in and the excess part comes out. Now this bolt goes into the largest canal, which is your palatal canal. And then when I cut it out, that's the one assembly that is got. This whole thing is luted with any of the luting cements. That's like your glass ionomer cement, your polycarbonate cement, or any cement that you want to use. So that's your final finished assembly that you have polished and ready for final impressions. And then you have your impressions taken and you get a crown fabricated on top of it. Now the same thing, if you want to do it for a lower, you can also do a multi-rooted split shank technique. If you see a diagrammatic description, what I've shown over here, the smallest molar, the largest is the distal root. So the distal canal, you prepare your distal canal with your piezo reamers. You do the same way you record it. In the mesial two canals, you just do with Gates Glidden drills to the depth of the canal, nothing more than that. The recording is exactly the same. You first take your light body and inject it into the distal canal. Take your custom made parapost, coat it with the tray adhesive, place it in the distal canal. Light body injected everywhere, allowed to set. Then take your putty and this thing ready. Take your light body, flow it on the remaining part, take a full tray impression, get it out, send it to the lab. He fabricates it as two separate units. Because these are two separate units and they have a mechanical interlocking in between. So if you see, what we have tried to explain over here is the interlocking that is created, which is a frictional interlocking, which makes sure that it doesn't come out or doesn't dislodge. So again, a very good technique that you can use for posterior teeth. Okay, just give me a minute, I'll just clear this up. Okay, now uh, I hope I've tried to make custom made posts as simple as I can. I repeat again, the only drawback with custom made posts, the number of sittings increase because you got to take impressions, you send it to the lab, it gets fabricated, comes back. The cost factor tends to increase because you got more number of sittings, you got the lab aspect coming into the picture. And if your is not correct, you will have to repeat the impressions and then send it back. Okay, so coming now to the ceramic posts. Now I have mentioned about ceramic posts in my lecture because it's a technique that was used a number of years ago, no more followed, purely because of the modulus of elasticity concept. It's extremely high as compared to dentine and very uh, kind of increased incidences of root fractures as well. uh, Sir, I'm again getting is it lagging
No,
or
no, you
not?
are very clear. I think so. It's on the part of the
Oh,
participant. There is
yeah,
a net
exactly,
issue.
because I'm in very good net. Fine. So I ignore that. I go ahead.
Yes.
I request the participants to please get your internet sorted out. And rather than sending me messages saying it's not clear, because I think I'm in good network. Okay. Now, let us understand how the ceramic post used to work. So Ivoclar used to be one of the earlier companies that used to come up with the ceramic post. It was called as the Cosmo post. I'm going to show you a clinical case. Trust me, if I get a case like this today, I would not do a ceramic post, but I'm showing it to you for descriptive purposes because I want the entire aspect covered in today's lecture. So Mr. Menezes comes and says that I have a discolored anterior tooth and I need you to sort it out, Dr. Sagar. Please do something for me. So I take clinical pictures, I do evaluation, and then I understand that his smile line is not too dangerous because his upper lip line does not really show a lot of gingiva. So I don't need to worry about the perioaesthetics in this case. I start examining the tooth and I notice tremendous amount of secondary caries on the root canal treated tooth. So the first aspect you do is to clear out all your secondary caries which is present to make sure that the remaining tooth structure is clean and healthy. Once you've done that, then comes the next aspect which is the restoration of the tooth. So the first thing that you see is it's a traumatic bite. If you see the bite over here, it's a pretty traumatic bite. And that's why instead of a glass fiber post, I would have probably gone ahead with any of the indirect restoration. That is why I chose a ceramic post in this case, purely because cosmetics was important for my patient. He wanted to go for a metal-free restoration. So if you see the impression again over here, it's followed in the same principle. I will record the post space with my light body, and then the whole part of the coronal structure is then picked up in the putty wash impression all together. If I can highlight it, you will be actually able to visualize very clearly that the post space is recorded by the light body itself. Now, one thing always to remember over here is you cannot directly inject the light body and then get it out. That's not how it works because the light body is it's not a very strong material. It's going to tear. The concept of the light body is to record the margins. So whenever you using light body to record the post space, always use either one of those custom made cast post para posts for supporting the light body, always coated with the tray adhesive, or use a metal post or anything like that which is going to support the light body when the impression comes out. Otherwise it's just going to tear and come out and you wouldn't be able to send a very clear image. So I enlarge it for all of you to see how the post space has been recorded in this one impression itself. Then you see the lab fabricates the ceramic post on the model and sends it back to me. I will then do the trial in the patient's mouth. The trial is correct. I will then cement it inside. And once the cementation is done, I will then do another. Sorry. The reason for treating his adjacent central was I was doing a little bit of smile correction as well. So that's why both of these are done. I did the laterals as well because I wanted a thorough smile designing to be done in his case, and his demand was to get his smile totally sorted out. But here we concentrate on the post and core because this is my lecture on post and core. So I make all my adjustments that are to be conveyed to the lab. I will then do my diagrammatic descriptions to my lab as to where my margins are short, where my margins need to be corrected, where I want some amount of additions, some amount of subtractions, and then when I get the final, that is how I finish the case. So you need to understand that when you have a compromised structure with a deep bite kind of cases, then the indirect restorations or the indirect post and cores are custom made ones serve better as compared to a glass fiber post or a carbon fiber port or a prefabricated post, considering the bite of the keys. However, said and done, they always have the issue with the root fractures because their modulus of elasticity is very high as compared to dentine. So that's the final finish that we achieve. He is pretty happy with the end result, and that's our motive. Now, uh, we'll discuss a little bit about the theoretical aspects of post and core now in the latter part of my lecture. What should be your actual post length? It cannot be arbitrary. You have to have a specific mathematical formula, a specific mathematical calculation to be doing. So if you remember in the beginning part of my lecture, I said about 4 to 5 millimeters of apical gutta percha should be left to make sure that you have a tight apical seal. Anything lesser than that, you are compromising the apical seal of your root canal, which is giving a chance of reinfection. So never ever leave lesser than 3 to 4 millimeters, you're in trouble. I would probably keep a benchmark as 5 mm or 5 length. Ideally, if you look at it, the simple concept first is the apical 5 millimeters that works. The others that you can take should be about the 2/3 1/3 ratio. In case you have a very long root, you should always have the third calculation, that is end the post halfway between the crestal bone and the root apex. Now where you use a case like this is if you have an say maxillary canine, which is having a working length of about 30-31 millimeters. You get rare cases of very long maxillary canines. You cannot have a post going right to 5 mm of the apical, but that's too long a post. So that's where you employ this kind of formula, wherein you should end the post halfway between the crestal bone and the root apex. That serves the purpose. And make sure that I always repeat 5 mm of apical structure, apical gutta percha, to not disturb the apical seal and cause any amount of any kind of reinfection. So that's basically a simple clinical description as to how the post space is there and how much should be the gutta percha and how much should be the post length and how much should be the core. Okay. Now, if that's about post length, you also need to understand about post diameter. Now, it's very easy for us to say you increase the diameter and you increase the resistance form. That is very true theoretically. But from the clinical aspect, you are increasing the chances of root fracture for a simple reason that with the increase in diameter, you are also removing more amount of your radicular dentine. I repeat again, the dentine once lost can never be returned back. You're never ever going to be able to replace it with any artificial material. So preserve the dentine as far as possible, and the diameter of the post is prepared very conservatively. You have the conservationist and then you have the proportionist. Let us understand how this works. The conservationist suggests that the narrowest diameter should always be used. It will allow, or it will you're doing minimum instrumentation of the post space. You would then have minimum amount of tooth structure which is removed, so you're making your tooth kind of resistant to fracture. The drawback of this is you have minimum retention as well. So that's the problem with the conservation technique. So if you see over here, the post space is prepared very conservatively. You have done hardly any amount of post space preparation. You've kept it exactly probably amount to the taper of your root canal preparation. The problem with this kind of preparation is you have minimum retention. The next approach, that is the preservationist. It advocates at least 1 mm of sound dentine should be present circumferentially to resist root fracture. This is a good principle that you can follow. So what this tells us is you have at least about a millimeter of sound tooth structure present all around the post, and that makes sure that you have sound dentine to preserve root fractures. You have a sufficient diameter of the post to make sure that you get adequate retention. The problem in this technique is that if you keep 1 mm as your formula, if you have a larger diameter tooth, you end up preparing a very large post space. So that's not always needed. And that is where the third formula comes into the picture, that is the proportionist. This advocates that the post length should not exceed 1/3 of the root width. So in simple words, it divides the root diameter into three aspects, three equal parts: 1/3, 1/3, 1/3. That seems to be the most clinically practical approach achieving a good diameter, and you can also achieve sound dentine present all around to make sure that the chances of root fracture are minimized. So that's about the root length or the post length and the post diameter, how you tend to calculate it. Now, coming to my luting agents, and I'm telling you this from my experience and my colleagues' experience, you will have one patient always throughout your career who will either tell you that, Dr. Saab, my crown has come out, can I use a Feviquick? Or he will tell you it came out and I used a Feviquick. That is why I put it, but this is the worst kind of thing you can ever do. Why I put it up is because a lot of laymen end up doing it. एक बार आपके करियर में कोई ना कोई आके आपको जरूर बोलेगा कि मैंने फेविक्विक यूज किया था करके for fixing my, don't ever even suggest this, please. The most ideal looting agents are your glass ionomer cements. Why I say glass ionomer cement is because that's your gold standard as far as looting of crowns go as well, and the same because it's got a good chemical bonding to your radicular dentine. It has good chemical bonding to the metal, so obviously the metal posts are going to have very good retention. The only problem is whenever you use a luting agent, you are going to have a cement interface. Remember, you've not achieved the monoblock principle that I spoke about. In the monoblock principle, it all is in one unison. Here you have a cement junction in between, which is going to be your weak link always. But amongst the cementation, this is your cement of choice. That's the glass ionomer cement. Polycarboxylate cement is also used predominantly, very good. It's an economical cement, also got the concept of chemical adhesion, so very, very good. The second point that I have put up is for the earlier glass ionomer cements, not the newer ones. When the resin modified GICs came into the market, the earliest ones had the problem of hygroscopic expansion, which your routine GIC also exhibits. That is why, if you remember, or I'm sure the clinicians will be able to place me, a lot of them have done their crown adjustments. The patient says, I feel fantastically correct. But the moment you cement it, the patient says, now I feel high. It's because GIC, even in the slightest amount of moisture, shows hygroscopic expansion, and that tends to push the crown slightly elevated eventually, which settles down, but the patient feels it immediately. Now, the earlier resin modified had the same problem, not the new resin modified. And that is why I say that over conventional GIC, resin modified GIC is a better cement for luting your posts and crowns because of the hygroscopic expansion getting eliminated. The newer resin modified glass ionomer cements do not have that issue at all. So if you're using glass ionomer to cement, resin modified is much better as compared to traditional GIC or conventional GIC. But even conventional GIC is not bad if you've done your isolations well. Okay. If you don't want to use the glass ionomers, you also have the dual cure cements which are present. So this one comes from Coltine. This is called Solosem. This is a self-adhesive resin cement. So you don't have a lot of issues with kind of etching. You don't have issues with you just have to make sure that the post space is dry, and then the Solosem works. You can also use a Relax U200 from 3M. That's also a very good cement. So you can use conventional GICs, you can use resin modified GICs, or you can use dual cure cements like a Solosem. And they have got a very thin cannula, so you can actually inject it into the post space. You just place the post inside and then you cure it, or you don't cure it also because it's dual cure. But if you cure it, it's faster to set, and the remaining part is then set by the dual cure mechanism. Now, I kept mentioning about ferrule effect, ferrule effect, ferrule effect in all my clinical cases. Let us actually theoretically understand what exactly is ferrule effect. So from the theory point of view, it's originated from a Latin word. That's how the term ferrule came into the picture. So the rule says that 1.5 to 2 mm of a ferrule height above the margin improves the long-term survival of an endodontically treated teeth with a post and core. That's exactly what I kept mentioning to you in the clinical cases that I said. 1.5 to 2 mm of sound tooth structure, supragingivally 360 degrees. That's your answer for a long-term success for your post and core. So this is the comparison of the two ferules. In the first one, if you notice over here, the it's exactly at the margin over here. So the crown is sitting on the core. The crown should never sit on the core. Here, the crown is sitting on sound tooth structure because you have the core which is present 2 mm supragingival. So I repeat this point. For a long-lasting post and core, 1.5 to 2 mm of sound tooth structure supragingivally 360 degrees. The crown margin should always sit on sound tooth structure and never ever on the core material directly. I'm sure you all saw this in Dr. Akil Reshamwala's presentation, but it applies here very, very effectively. So I'm showing this all over again. If you see the shear forces that are being taken on the cingulum portion over here and the labial portion over here. That is exactly why you get cases of a root canal and a crown. The patient breaks the crown with the tooth and comes back to your clinic saying it broke. And we as dentists, what do? My crown is intact, your tooth broke. So it's not my fault. I think we should start accepting where we are going wrong when we don't establish a good ferrule effect and give a crown. That's the problem that tends to happen. So now if you have about 0.5 mm of ferrule that you've created, you will automatically notice on the palatal aspect and the labial aspect the shear forces are going down. If you have a millimeter, it's even going down. If you have a millimeter and a half, it's practically absent. And if you have 2 millimeters, it's ideal. So I repeat again, this point is very important for clinicians and people who are practicing. 1.5 to 2 mm of sound tooth structure supragingivally 360 degrees. Make sure that the margins of your preparation always sit on sound tooth structure, never on the core directly. That's when you will have a long lasting restoration and it functions in unison very effectively. Okay, so that's a very simple way of describing a no ferrule effect versus a very, very ideal ferrule effect of a 2 mm supragingival tooth structure. Okay, I think this is already explained to you, so I don't really need to go much into the detail of this. Uh, where does the ferrule work? It resists the lateral forces on the post. So obviously the chances of the post fracturing inside are eliminated. The chances of the post and core coming out in total is eliminated. The chances of the of the restoration, which is ideal to make sure that it's a long lasting restoration for the patient. Now, whenever you do a post space, this is always good to give. That's called as the anti-rotational notch. It's a resistance kind of form that is given. Always remember, it is given on the thickest part. So it makes sure that the post that goes in has an artificial kind of locking effect that's created inside. It's called as an anti-rotational notch. Always give it on the thickest or the bulkiest part so that you don't compromise on the radicular dentine, and it gives a natural kind of a lock to your post to prevent the dislodgement of your post. Okay, what are the kinds of failures that you will see? In general, you usually will get a failure in a post and core if you haven't followed the basic principles of post and core. You've not taken a good post length, you've not taken a correct post diameter, you've not followed the principles of ferrule, then obviously the failures come. Where do the failures come? Your post fractures, your root fractures, your core fractures, the post dislodges on its own, or you have an aesthetic failure in the sense, if you remember the image of the ferrule labial forces that are coming, the PFM restoration, for example, may show a chip on the labial aspect because the forces on the labial are too strong in an absence of the ferrule to have the porcelain bonded to the metal. So there is an aesthetic failure that tends to come in by chipping of the porcelain on the labial aspect. So if you follow the principles, usually the failures are bare minimum. I've already kind of during my clinical cases spoken about the preparation of the space. So you usually would either do it by removing the gada parcha by a hot endodontic instrument, but ideally you would do it by using a laser ablation, which is called as a laser ablation. for a narrow diameter tooth or a number 3 for a wider diameter tooth. So for example, if you're doing a lateral incisor, or which is a narrow diameter, you prefer it to a number 2 piezo reamer. But if you're doing a kind of a bulky distal canal of a lower molar or a parietal canal of an upper molar, you probably go to a piezo 3 at least in those cases. Okay. During your post space preparation, you can accidentally, if you have very kind of high speed on your piezo reamer in the micromotor, you may accidentally push the gutta percha beyond the apex during the post phase preparation if your apical seal is not established correctly, or you may actually pull off the gutta percha a little bit, so you may hamper the apical seal again. So these are another couple of kinds of failures that may occur if you've gone ahead with too fast a piezo reamer. So always make sure that you don't do a piezo reamer with a aggressive kind of RPM. Make sure that you use it at about mid speed. That is good enough. Okay. Uh, Another thing that you can probably do as an error is cause overzealous or excessive enlargement in the pretext of using a larger diameter post, and that tends to really weaken the root and make it susceptible to fracture over the years to come. So don't do that as well. Always remember that for narrow diameters, go up to about piezo 2, and for larger, maybe about piezo 3. Don't overzealously enlarge it. You're actually weakening the tooth and doing nothing else. Okay. That's another kind of error which you may create if you've angulated the piezo reamer in an entirely wrong direction. You may actually perforate the tooth altogether. So always make sure that it's gone in the right direction, parallel to the long axis of the tooth, so that you don't create an error like this. The core, which is the last part of my lecture, uh, the part of the post becomes technique sensitive, and so it's very important for the mathematical calculation that I just said about the post diameter, post length, and the luting. When it comes to core, it becomes a material of choice which one you are going to use. So the core by definition is the supragingival portion that replaces the coronal part of the tooth structure that is missing. It basically acts as a miniature crown. Now, what are your ideal requirements of your core material? It's pretty similar to what your post ideal requirements were. Biocompatibility, you need ease in manipulation, you need good ability to bond, you need a coefficient of thermal expansion which is similar to dentine, minimum amount of water absorption, because otherwise if there is salivary contamination expand, it's going to really affect the bond between the core and the tooth and the bond between the post and the core. It should be dimensionally stable, always low in cost because we're an economically driven society. And if you can make sure it's contrasting in color when it's used for not only anterior teeth, but I would say in all kinds of teeth. So consider a case like this. If you have a blue colored core material vis-a-vis a tooth colored core material, the advantage that happens is when you're doing a crown preparation, you know exactly where your tooth is and where your core is. So you know where to finish your margin. Second advantage is, for example, if the tooth has to be retreated for some reason or the other, you yourself or any other dentist who's having to retreat it knows exactly what the core is. Otherwise, you end up removing a lot of excess tooth structure and weakening the tooth. So I'm a big fan of using a separate colored core material. It gives you a better chance of preservation and maintaining the tooth structure. If you come traditionally, amalgam was your most commonly used core build-up material for years together. The composites and all have come in more or less later. Glass ionomer, I don't think serves as a purpose of core build-up. It just doesn't have the kind of strength. Maybe if you've done a very conservative axis opening in the anterior tooth, maybe you can say fair enough. But for posterior teeth, not at all recommended at all. Cast metal, yes, these are used as core build-up materials, but these are obviously because it's cast metal is fabricated by the lab and then it's placed in the oral cavity. Now, The advantage that amalgam has is it's got extremely high strength. One of the strongest materials, got long lasting, it's got years of use and years of success. Very easy to manipulate, reasonably economical. So it's got a lot of advantages. But the disadvantages of amalgam are also pretty fold. It's got tendency to corrosion, discoloration of gingiva is known. Aesthetics is pathetic because it's obviously not at all close to the tooth structure at all. And the mechanism of adhesion is mechanical, it's not chemical. That's where composites come into the picture. Aesthetics get improved, and you have the advantage of bonding. It's not mechanical, but it's a bonded restoration. So it's obviously much better in kind of, the bond between the core and the post and the core and the tooth. You get setting immediately because most of these are light cured and dual cured vis-a-vis amalgam, where you have to actually wait for it to set. So composite resins are now the materials of choice as far as core build-up materials are used. Of course, I always repeat, no material is inch perfect. It comes with its share of disadvantages. So you got polymerization shrinkage, which leads to a gap. Shrinkage, micro leakage comes straight away. So obviously that's a problem. If there is water contamination or sorption, as they say, during polymerization, you've gone for an absolute toss with composite because it tends to swell, debond. Dimensionally unstable, yes, if you are not used to working with it. If you get the hang of composite, it's a good material. And well, not to be used in excessively damaged teeth. So if you remember the case I showed you for bolt and core, those are the kind of cases you should not use composites. You can go for the bolt and core concept. It works much better. I don't recommend glass ionomer because we have a lot of students in this lecture as well. I've kind of included it in my theory. So it's got advantages. Yes, it's got fluoride release, anti-karyogenic. Of course, it's kind of chemically adhering, but it's just not strong enough. So I don't really recommend for clinicians glass ionomer as a core build-up material. Please don't use it at all. Cast metal is good if you are using it for badly mutilated teeth because it tends to come externally fabricated, got tremendous strength because it's used with a cast metal or fabricated by a cast metal. And obviously, because it's externally fabricated, the retention is much better. So it prevents the dislodgement. Of course, it's got its share of disadvantages as well because the root fracture incidence increases because the modulus of elasticity is again is very different. It's expensive because it's fabricated externally and it's an expensive material. So you got the problem of cost factor, and it's time consuming because you got to send it to the lab and it comes back. So the time becomes a major issue with cast restorations. Now, cementation is where I would like, to kind of place a little bit of stress on. We're on the last part of my lecture now, because that's where the cementation protocols come into the picture. Now, two things are very critical to understand when you're doing a cement placement or the cementation of the post. There should be no air bubbles at all which is present inside. So make sure that when the cement is being luted, there are no air bubbles that get incorporated. But before that, before you use any kind of cement, it's important to dry the canal so that there is no contamination. And second is to prepare the canal. Now, I'm sure all of you will understand when you use piezo reamers to do your post-paste preparation, you are generating a lot of debris. You're generating smear layer, you're generating debris of gutta percha remnants, XYZ, you name it. It's like a slush inside. You are never ever going to have any kind of cementation to the dentine with so much of debris present inside the canal wall. So you got to first clean it out. The best way to clean it out is by using 17% EDTA. So post-paste preparation is followed by post-paste for the canal to make sure that you remove the smear layer by using 17% EDTA as an irrigant and agitate it inside so that smear deposits become loose and are eliminated out. Once the smear layer is eliminated out, you will dry the canal. It's very critical to dry the canal so that there is no moisture. Otherwise, you use GIC, you use dual cure cement, it's going to have a problem in any of them. So make sure that you follow these protocols very correctly. As I said, 17% EDTA for 30 seconds. Why they say is you should follow it with 5.25% sodium hypochlorite. You don't want any remnants of EDTA inside. Similarly, after 5.25% hypochlorite, you should rinse it with distilled water or saline so that there is no remnants of sodium hypochlorite inside also. Dry it with paper points and then use any of your cements of choice. As I mentioned, you can use conventional GICs, you use resin modified GICs, you use dual cure cements, whatever you like. But prior to this, it's very critical to have your canal space prepared well. So 17% EDTA, 5.25% sodium hypochlorite, dry the canal and then use your cement. Okay. Now, post design. Active, never. I know it said you should use it for short. I would never recommend. Instead, if you have a short, you actually go in for a custom made kind of post, but it should always be passive. Active, you are inviting root fractures. So never ever go for active post designs. Should always be passive. Make sure that you have sufficient amount of post space that is done, and the canal is not made like a funnel, so that creates a problem for your retention. I've already discussed, I guess, about post length, so we're not going into details about it. Post diameter I have discussed, but I wanted to show you a clinical image as to what happens if you make it an overzealous enlargement. You have don't make it very large in the assumption that you're going to get an increased retention. Try and be as conservative as possible. Okay. This cement placement with lentulose, that tends to make sure that you kind of prevent the air bubbles that come in. So lentulose are kind of good. These are your two main, or I would say the workhorses of your core build-up materials as far as dual cure composites go. That's your Paracore and Luxacore. These are your two most supreme materials that are present in the market. Now, there are certain advantages, I would say, with Paracore over Luxacore. And if you understand, when you are using Paracore vis-a-vis Luxacore, you have lesser amount of steps. So when I just mentioned about, say, for example, you need to prepare the canal with the 17% EDTA, and then you got to, go ahead with the drying the canal and all. With a paracore, what happens is they tend to give you something like this. I'll just show you. They'll give you three kinds of separate bottles. One is a conditioner. So you can actually coat the canal with the conditioner that removes the smear layer and actually incorporates the smear layer in the bonding. And then you have a mixture of two bottles, adhesive A and adhesive B, which are mixed together, coated. Place the paracore in the canal, place the post, cure it together. It's a one unit monoblock phenomenon. This does not come in a Luxa core, because in a Luxa core you have to etch it, you have to wash it. So please remember, the more number of steps you have which employs washing and drying, the increase is the chance of contamination and of dislodgement. You've got para post formers which are present. So instead of arbitrarily just building up the tooth, you can just flow the material in the core formers, place it on the post and cure it. So it's actually formed your core directly. If you see, these are in numbers. So each number comes in specific sizes for specific teeth. The number one is for smaller teeth, say lower anteriors. As you go in increased number of sizes, you would have a larger amount of tooth structure that can be built back for your molars and premolars. Okay. Now, these are your parapost formers which are available. This is not too important. This is again a clinical case wherein we've shown that. आप यहाँ रख दीजिए, मैं चला जाता हूँ. Thank you very much. Uh, we've done a rubber dam isolation. We've done the post phase preparation. We've used the fiber post. We've conditioned it with the conditioner. We've then mixed the A and B adhesives. and then you flow the entire paracore, place the post and cure it. Monoblock phenomenon. There is no weak link of using a cementation over here. So the strength that you get and the longevity is much better in cases like this. Uh, Again, where I keep stressing on this point, modulus of elasticity. If you see, dentine is 18.6. The closest you get is with the glass fiber post, which is 40. Everything else is tremendously high. Carbon fiber is about 120. Zirconium is 170. It's practically a disaster to be using zirconium posts. And look at steel posts, the metal ones. It's absolutely crazy. So always, I repeat ahead, prefer the fiber posts because they got the modulus of elasticity closest to dentine. Uh, Last clinical case of a patient called Nikhil, wherein I get a case like this coming in, and he says, I'm not happy with my smile. Why I've given this case? Have I lost connection or am I still there? Can someone just place me back?
You're there, Sagar, very
Thank
much.
you very much. Thank you very much. So, coming to the clinical success, you get less root fractures in fiber posts than metal posts. It's very, very important with aesthetics, and it's also easy to remove just in case if you have to do retreatments. My last clinical case of a patient called Nikhil, wherein I get a case like this coming in and he says, I'm not happy with my smile. Why I've given this case as my last case is we've got all the theory covered now for you to understand the practical aspect of this case. So I don't like my smile is what Nikhil says, which is for obvious reasons. You can see the dark margin under the crown. So we remove the crowns and this is what you get. You get one of the central which is totally decayed underneath the stump, and then the other one which is relatively okay. So you start the first process of removing all the secondary caries. You also see I've used a little bit of electrocautery for that to create a little bit of my ferrule effect. Once all the secondary dentin is removed, I then take my fiber post and cure it inside after my post-paste preparation. We've done the core build-up. After that, with the paracore over here, so I've achieved the monoblock phenomenon. I will always temporize the patient, never ever send him without temporization. That's very critical. I will then recall him back, do my shade selections, do my final preparations, and then I will take my impressions, and then I have my metal free restorations given to him to achieve my best aesthetics as we can. So I really hope through this lecture, my teachers, students, colleagues, friends, I have tried to cover a huge topic in probably just about 2 hours. It's very difficult to cover such a massive topic in such a short time. I've tried to keep as many clinical cases as I could to make sure that I'm conveying my point in a better way. I hope you guys have sincerely benefited from this lecture. And if you have any questions, I am more than available now to answer. Thank you very much.
Thank you, Sagar, for this amazing lecture and for sharing your knowledge.
Thank you, sir.
Now I'd like to request Dr. Monshi Guleria to kindly moderate the question and answer section.
Yeah, sure.
Dr. Monshi, please.
Hello, good evening, sir. So it was really informative, very clear, precise, and structured. Okay, so
Thank
we
you, ma'am.
have few questions over here, and I would just like to unmute them so that they can ask you directly.
Sure, I'm absolutely okay with it.
Okay, so the first question is from Dr. Chinmay. Okay, Chinmay, you can talk now. Uh,
Yes, ma'am.
Please.
Good evening, sir.
Yeah, good evening, Chinmay.
Sir, my first question is, sir, how to select the post size, sir?
See, as I explained you, Chinmay, you need to understand the size of the post usually will depend on two aspects. One is your post length and one is your post diameter. I think I've
Yes, sir.
stressed a lot on my lecture already that vis-a-vis the length, you need to have the principle of at least 5 mm of apical gutta percha present. Otherwise,
Yes,
if it's
sir.
a very long root, then you go to half the length between the apex and the crest of the bone. Regarding the diameter, I am always of the principle that you must have as much as sound dentine all around to make sure that you have sufficient forces, sufficient amount of strength for the root to resist the masticatory forces. So if you're doing, for example, a maxillary or a mandibular molar, which is having a bulkier root structure, and it should be say approximately number 2, which will correspond to a number 2 piezoring. And if you're doing a molar or a, for example, a maxillary or a mandibular molar, which is having a bulkier root structure, and you are having sufficient amount of radicular dentine, you can go up to a piezo number 3 to make sure you achieve good amount of retention for your post, and also you have decent amount of radicular dentine present all around it for resisting your masticatory forces. I hope that answers your question.
Yes, sir.
So next question we have from Dr. Rakshana now.
Good
Rakshana,
evening, sir. Yes,
Good
ma'am.
evening, Ravi.
Good evening, sir. Sir, my question is that what is the ideal luting agent for glass fiber posts, and how does isolation matters in case of resin modified cement also?
So, if you ask me very honestly, your ideal cement for a glass fiber post should always be dual cure cement, because I kept stressing on the principle of a monoblock phenomenon. Now, what
Yes, sir.
happens is the glass fiber posts come in with a resin matrix impregnated. And if you use a dual cure cement, that's exactly where your dual cure cement will go in and bond to your fiber post and achieve a monoblock phenomenon. If you use traditional cements like a glass ionomer or a polycarboxylate, the cement is always going to act as a weak link vis-a-vis a resin cement, which is going to have a one unit between the post, the core, and the radicular dentine. So always prefer a dual cure cement. That is regarding your cementation. As
Yes.
far as isolation goes, Rakshina, whether you use a glass ionomer cement or you use a dual cure cement, it's extremely critical, because a moisture contamination is just going to affect any of these cement as far as setting goes and the final kind of reaction goes, because there's going to be expansion, there's going to be a loss of strength. So it's very critical that isolation is maintained throughout the cementation protocol with any kind of cement.
Yes.
I
Thank you,
hope
sir.
it.
Dr. Prashant would also like to ask a question.
Sorry.
Dr. Prashant, sir.
Yes, yes.
Prashant, you can. He's not there. Prashant, you can ask now.
Hello. Yes, yes, sir. Yes, ma'am. Hello,
Yes,
sir.
Prashant, go ahead.
Sir,
Go ahead, Prashant. I can hear
sir.
you.
Hi, sir. Sir, which is the best chair side surface treatment for post, sir?
Sorry, which is the best chair size?
Surface treatment for post.
See, usually most of the posts nowadays come pre-treated. Okay,
Okay, sir.
you don't have
Yes,
to
sir.
actually treat. Most of them are being are actually pre-etched and sent by the companies.
Okay,
If
sir.
you
Okay,
have
sir.
to, then you have to condition the post prior to cementation. Depends on the kind of cementation protocol and the cement brand you use. Some cements suggest you to apply the bonding agent on the entire post and cure it. Some suggest you to just apply a silane. So it
Yes,
depends on
sir.
the kind of cement you're using prior to cementation, which is your chair side treatment for your post. But to answer your question, almost practically all of them now come pre-treated or pre-etched to the practitioner, so you don't have to actually etch it over.
Yes, sir. Yes, sir. Thank you.
No way.
Okay. Dr.
I
Jeevan
think,
would like to
yeah,
ask you a question.
yeah, sure.
Dr. Jeevan, we can hear you now.
Good evening, sir.
Yeah, good evening, Jeevan. Yes.
Sir, how much that biological width can be violated, sir? In this case?
Sorry, come again. A biologic width. Okay,
Yes,
look,
sir.
I'll be very honest with you. This is not the kind of lecture where we are talking about the biologic width concept, because that's another half an hour into the discussion. So
Yes, sir.
basically, what you do in a case like this is, before you start your crown lengthening, you take your periodontal probe and check for the attachment apparatus that you have, and based on the calculation you either do just gingival crown lengthening, or if you are going to kind of encroach, then you will need osseous reduction also. This being a kind of a restorative lecture, I would not want to go too much into the biologic will, because that's a periodontium kind of aspect, and we'd be kind of wasting a lot of time on it. But to answer your question, you cannot encroach upon the biologic width. It's simple as that. So there's no way that you are going to say that how much can we encroach. You cannot encroach. The moment you know that there is a concept, or there's a scenario like that happening, you got to plan your osseous reduction in a very, very judicious way, either by yourself or in conjunction with a periodontist, to make sure that your case is successful. I hope that answers.
Thank you, sir.
Dr. Ashish? Dr. Ashish, you are unmute now. You can ask your question. He is unable to unmute himself. Okay, I think, sir, we have covered almost everything, and whatever questions that we have got in the question and answer section, most of that you have covered in your presentation, sir. Thank you so much. I think we have Ashish now. Ashish, you are unmuted now. You can ask.
Good evening, sir.
Good evening, Ashish. Tell me.
Good evening, sir.
Good evening.
Sir, how can root perforations? Sir, how can root perforations be avoided, sir?
Okay. So I think the simplest way of avoiding a root perforation is to probably take preoperative radiographs prior to starting. If you are unsure, then you can take a radiograph with the piezo reamer in place without it in motion, and confirm it with another radiograph to make sure that you've gone in the right angulation. As I said in my lecture, that you need to go parallel to the long axis of the tooth. Otherwise, you end up perforating the lateral surface. So if you're unsure, you can kind of take a preoperative X-ray to understand the angulation of the tooth, and also one just with the piezo reamer in place without spinning it, to confirm whether you're going in the right direction to avoid the perforation. I hope that answers it.
Yes, thank you, sir.
You're welcome.
Okay, sir. Sir, thank you so much.
Thank you, Moichi.
One last question from Dr.
Sure.
Okay, Dr.
Sure.
Please unmute yourself.
Hello, sir. Good evening, sir.
Good evening, Raj.
So, can we post place in mesiobuccal or distobuccal canal if I have palatal walls intact and more surface is missing on mesiobuccal or distobuccal canal?
Okay.
Can we place post on mesiobuccal canal or other canal rather than the palatal canal of maxillary molar or distal canal?
Okay, I get your question. So I think, Rajvardhan, you must understand this one basic concept. The post must always primarily be placed in the largest canal, irrespective of wherever your tooth structure is missing. So for example, if you say a maxillary molar, even if you have a palatal wall present and a buccal wall missing, why you always prefer in the palatal is because it's a larger canal. You got a larger amount of diameter present over there. The anatomy of your mesiobuccal and distobuccal inherently is narrower. It has curvatures which are not identified in a two-dimensional X-ray, because your radiographs are generally two-dimensional and not three-dimensional. So you are increasing the chances of a perforation by placing it. So what you can do is, what we do clinically is do a post-space preparation in the largest canal, which is your palatal or the distal, and the mesiobuccal or distobuccal in a maxilla, and the mesiobuccal and the mesiolingual in the mandible are just prepped in with Gates Glidden drills to 1, 2, and 3 numbers, just till the cutting head of the gates. And when the core buildup is being done, you actually inject the core buildup material, the dual cure, right from within. So you have those composite tags which go inside, which act as an increased retentive factor for your mesiobuccal and distobuccal canals as well. But preferably, it's always recommended to avoid placing in these to avoid the chances of perforations. I hope that answers your question.
Yes, sir. Yes.
Thank you, Dr. Sagar, for clearing all the doubts of the participants. Dr. Sagar, is there anything else you want to cover before we wrap up?
As precise and informative as I could. I think I've tried to cover almost all aspects of post and core in my lecture, sir. Uh, More than this, I don't think is clinically relevant. Of course, you're never going to have a end to it, but I think we've kind of covered most of what's necessary.
Thank you, Sagar. If
Thank you, sir.
anyone wishes to revisit this webinar, they can go on to the Mansarovar Global University YouTube channel. Before we conclude, I would like to thank Mr. Gaurav Tiwari, sir, Pro-Chancellor, Mansarovar Global University, and CED, Mansarovar Group of Institution, for his constant support and encouragement. I'd also like to thank everyone for joining us today, and I hope you all had a worthwhile time. See you all again next time. Bye as of now.
Bye bye.